And what I'm going to do for the next 12 minutes or so is to address this topic of LDLC management, whether it based on the target or on the base of the dose. What I'm going to do for the next 10-12 minutes is on this topic is an overview of what I'm going to consider, all these aspects of the topic. The first thing is that we must remember the global burden of the cardiovascular disease. Nearly 31% of the global death is due to the cardiovascular disease. And about 85% of all CV deaths are due to the heart attack and the stroke. And nearly 75% of all CV deaths occur in the low and the middle income countries. So particularly for our part of the world, it's very, very relevant. If you have to see the recent reduction after starting the statin therapy, still the heart disease remains high, particularly in India and the South Asians. If you see here, in the past 2 decades, definitely the death due to the disease of the heart have declined, but yet the number of deaths remain high, and this is because of the residual risk. And the residual risk is the risk for incident CV event or the progression of the CV disease that persists even after the standard of care what we are doing at present. If you have to see the total, the million death, 2.1 million death due to the heart element in India at all ages, even including the stroke-related death, as shown in these two diagrams. There's a different divergent, the incidences in the stroke as well as the myocardial infarction. And if you see the various category where the mortality as shown here per lakh, if it is more than 190, this color, and if it is between 150 to 190, this orange color, etc., and that very clearly depicts, it's how it is concentrated at a different region between the MI and the stroke incidence. Now, Salim Yusuf long back, almost 16 years ago, has shown in inter-art study that almost 9 modifiable risk factors are accounting for nearly 95% of the first MI risk. And if you have to see the lipid abnormality, and if you see the patient at risk percentage, nearly 50% is due to the lipid, again telling us that the lipid abnormality is one of the important reasons for our problem. Now, when you see the prevalence of various dyslipid in India, this is one of the study of the hospital database looking at various the factor. If you see here, LDL more than 100 milligram, you see nearly 60% or more of the population, we have LDL more than 100. Of course, we have various different types of dyslipidemia, unlike the Western dyslipidemia, like we have the ITG, we have low, the HDLC, we have ILP, etc. Now, the raised LDL is observed in up to 70% of the CAD patient in India, as shown in the Clarify registry, which is quite an old registry. And if you see, almost 1/3 of the patient only achieve the target LDLC, as shown by the DICE study. And we know that every 40 milligram reduction in the LDLC, reduction of CV event, about 20 to 25%. And also several statin studies have demonstrated that there's a qualitative and quantitative linear relationship between the LDLC and the CV event rates. This is one of the studies where I was study showing that the LDLC is a major contributor to the atherosclerotic progression, as shown in the study like reversal asteroid. Lower the LDL, the better is the reduction of the atherosclerotic progression or even the reduction of the atherosclerotic volume. This is one concept which is very, very important, what we call it as the cumulative over time effect of the LDLC. Like if you see this graph, when you see a homozygous FH case, you see by the age of 12.5 years, almost 150 LDL. And if you see as the age advances, the rise of the LDL. And if you see without the FH, see the way the LDL reach of 150 is at the age of 55. And if you see a case of FH heterozygous without any intervention, almost at the age of 35, they get the 150 level. And if you start early statin, see the curve goes almost that LDL of 150 reaches at the age of 53. And if you start little later age, then again at the age of 48 years. Clearly suggesting that the cumulative effect of LDL over time is an important concept. Lower the LDL level have been associated with the lower rate of major coronary events. It has been shown almost 22% reduction in the CV mortality and about 12% reduction in the total mortality over 5 years, both in the primary and the secondary prevention studies. Now, this has been very well clearly demonstrated. Lower the LDL and lower is the risk of CV event, very clearly shown by TNT study, Jupiter, and the PROVID study. You see the LDLc less than 64, see the p-value of 0.001. So also the p-value is very, very significant. Even here between the dose of statin, and when you see LDLc less than 50, as also in PROVID, you see the hazard ratio, lower is the better. Now, if you have to see the CV risk reduction is consistent even irrespective of independent of the baseline LDLc. This is one trial, almost the meta-analysis of nearly 1,69,000 plus patients in 26 trials, as cholesterol treatment trial, the collaboration. And if you see this higher the statin dose, and you see the level of the LDL at the level baseline LDL, you see the hazard ratio going favoring favoring the statin dose of higher dose application. Now, if you see the guideline for the LDLc management, this is the European guideline which has shown when presented last year. Both the ESC, European Society of Cardiology, and the European Atherosclerosis Society have classified into low, moderate, high, and the very high based on the score level. Less than 1 is low, and more than the 10 is very high, and in between 1 to 5 is moderate, and high is between 5 to 10. And they basically said in the low and the moderate, the reduction of LDL treatment goal is about 115 low, 100 in moderate, whereas high is 70 and very high is 55. If you see the part 3 document of Lipid Association of India, which is just published last month in the JAPI, where we have shown that in the low and the moderate, the treatment target is 100 milligram, in the high risk is about 70, in the very high 55, and we have come out with the extreme risk category, wherein we have a provision even to get the LDL to less than 30. That depends upon, as shown in this slide, the extreme risk group, we have 2 categories, and this is what been mentioned in the part 3 document of the consensus statement of the Lipid Association of India. Just last month it was published, wherein we have got a goal of even less than 30 when you have a patient with a polyvascular disease, recurrent ACS within 12 months, homozygous familial hypercholesterolemia, etc. So basically, the level depends upon the risk at what we are starting this therapy. We know the statins are the cornerstone of dyslipidemia, particularly the high LDLc. See the reduction in the MACE with the statin. Various studies, both the primary and secondary prevention studies, have shown clear cut. And also this shows that higher the intensity of the statin, greater risk reduction with the high intensity statin, as shown here in all the trial I just showed earlier. PROVID TME22, ideal trial, TNT trial, showing high intensity statin versus the moderate to intensity, high intensity is better. If you see the TNT study, wherein 80 versus 10, the reduction of the cardiovascular risk is more with 80 milligram, and the incremental risk reduction was seen, as you see here in this particular slide, in all non-fatal MI, stroke, revascularization for heart failure, and the angina. And also the aggressive statin therapy, the result was shown both in metabolic syndrome with coronary artery disease and without the metabolic syndrome, suggesting which is metabolic syndrome is one of the important constituents for Indian dyslipidemia. So it is going to be useful. If you see the OCT study, which has clearly shown higher the dose of statin, the fibrous, the thickness of the fibrous core thickness reduces with the higher dose of statin. So higher the dose of statin, the faster and the better reduction of the fibrous core. Why lowest is the best? Because if you see in the meta-analysis of the recent trial, even target as low as 20 milligram was shown to further reduce the cardiovascular risk. As shown by the meta-analysis of the cholesterol treatment trial collaboration, PROVID, Fourier, and REVEAL study, in all the events like major vascular event, coronary artery death, MI, ischemia, stroke, coronary vascularization, see the hazard ratio all favoring that the lower the LDL, the better is the lower is the further reduction of the CV risk. If you also see in the Fourier study, further ultra low LDL, wherein the LDL is reduced further down, you see the reduction of the risk of major CV event. and major CV events progressively decline with the lowered achieved LDLC at the end of 4 weeks. And this is one of the sub-study of the Fourier study. How low is safe and is it safe, and how low we should go? How low is low and safe? Cellular acquisition of cholesterol can be from multiple sources. It is not dependent on the plasma LDL. So we need not have to worry that the cell function will alter if you get the LDL low, because the cell can function without the plasma LDL. Brain has its independent de novo synthesis. If you see PCSK9 loss of function, they're living with the LDL less than 15, and they're safely living for long period. And there is no safety concern of the hemorrhagic stroke as well as the neurocognitive function, even the low the LDL level. As I said, cellular acquisition occurs, the both extracellular and intracellular way of preparing the synthesis of cholesterol occurs in the cell. So the plasma LDL don't alter the cellular function. If you see the Jupiter study where LDL less than 50 versus more than 50, again the adverse events again are not significantly different when we have LDL getting less than 50. If you see the LDL lowering the always as a concern of the hemorrhagic stroke, but now the trial have clearly shown that is not associated with the increased risk of hemorrhagic stroke. Earlier trial like Miracle trial has shown that the hemorrhagic stroke was one downside, which is now not shown in the recent trial. So also the new onset diabetes mellitus is one area where we worry when we get the LDL low. So that also has been shown now that there is no increased risk of new onset diabetes in any of the trial individually or when meta-analyzed. Whoever is going to get the new onset diabetes mellitus, that pre-diabetic, family history, obese patient, or who are destined to have diabetes are the people who get statin-induced diabetes. If you see the Fourier trial, very low LDL, less than 20, and similar safety parameter. There is no abnormality. If you see all the side effects, like whether you have a cancer, cataract, new diabetes, all neurocognitive dysfunction, at the end of 4 weeks, they have shown that there is no difference in the side effect. Now coming to the longer therapy with high intensity statin is required. Why it is required? Longer is the better, because it takes time for complete clinical benefit at the time of LDL lowering. I did mention in one of the slides is the cumulative effect of the LDL effect over time, and longer is the better. Lowest LDL are best because there is no safety concern. At the same time, there is incremental benefit of the CV risk, etc. Incremental benefit to the absolute LDL reduction is seen because they have reduced the LDL, they have the residual risk is reduced. Now, just to conclude the last slide, why we need to lower the LDL in India particularly, because if you follow the ACC and European guideline, CVD mortality has increased in India by 40.7%, whereas it decreased by 50% USA and European guideline when we follow their guideline. But even if we follow the guideline, our disease has increased, not reduced. We developed heart disease 10 years earlier than the Americans, which is very well documented in many studies. Approximately 1 in 4 patients of us are less than 40 years. They die due to coronary artery disease. So our incidence and our prevalence is more. CAD is more severe and comes higher and carries a higher mortality as compared to the non-Asian countries, and that is a huge burden for us. Lipid abnormality is different from the other ethnic groups. As I mentioned, you have a typical Indian dyslipidemia, normal or mildly raised LDL, that also small dense LDL. We have got the high triglyceride, we have the non-HDL cholesterol, we have the remnant cholesterol, and they are the cause for residual risk. We have the low HDL risk, again, probably genetic predisposition. We have high prevalence of increased LPA, so we have to target the LDL low. One of the therapy for increased LPA today is to get the LDL as low as possible, and high LDL HDL ratio ApoB A1 as shown in the India Heart study, which I shown in my earlier study by Salim Yusuf, and increased small dense LDL cholesterol particles are the problem in Indian dyslipidemia. Average LDL in American population is 106 and ours is 94. So we get coronary artery disease, vascular disease at the lower LDL. So even the lower LDL is higher cardiac events, and therefore we have to redefine our indication. Recent European guidelines also recommends, even less than 55 very high risk, as I showed in one of the slides, based on score risk. And if you see now, if in extreme risk, even the European guidelines have suggested that there is a scope of getting 30 milligram or less than that. And now if you see, even the ACC guideline 2019 mentions that the South Asians as ethnicity is one of the risk enhancer. So now clearly the Western guideline, including the American or the European guidelines, are giving importance to the lowering of the LDL to the more significant level than what we are doing so far, and that is to decrease the reduction of the cardiac events, even as shown in the Fourier trial and the post-hoc analysis of the improved trial, and with a significant the insignificant adverse effects. It could be not only statin, even the non-statin drugs, like maybe use of the ezetimibe, maybe the use of PCSK inhibitor, or for that matter, if you get the bempedoic acid. So the combination of various statin and non-statin based therapy, but essentially targeting the LDL at the low level. Thank you very much for the patient here.